get started with this interesting discussion about health infrastructures with a long-term perspective. So I'm not Ed Kelley, just in case anybody was wondering. That's Ed Kelley up there. So he unfortunately is not able to join us, and I guess he'll explain in a moment why, and he'll also explain a little bit the layout of this session. But perhaps before I give the word to Ed, I would just like to welcome the other panelists that we have here. So on my left, we have Marcos Paulos from Ethiopia. And on my right, we have Nana Mensah Abrampah from, from WHO, but originally from Ghana, right? Yeah. So we had actually foreseen another panelist, Issam Khai, from Morocco, but he disappeared. We have no idea what happened to him. Anyway, he's not here. Without more ado, I think I'll give the word to you, Ed. I don't know, Ed, whether you can see us. No?
Yeah, wave if you have difficulty hearing me. But it's a pleasure to at least be able to join you at a distance, and very big thanks to John for agreeing to step in to chair the session and to offer the kind of traffic control for the question and answers. And also thanks very much to the organizers for inviting WHO for the first time to be part of this important knowledge sharing meeting. I think knowledge management, if you look at public health and the great gains in public health over the past 5 decades, at their heart there has been the behavior change that's been inherent or the advances that have been achieved with public or within the medical provider community have all been around knowledge management and knowledge transfer and exchange. And I think the different fora for that are usually limited for all of us to within our particular arenas, within our particular scientific disciplines. And providing an opportunity like this to share across disciplines is a very rare event. So the organizers are to be complimented for that, and we hope that this is not a one-off arrangement, particularly since with the help of Lufthansa, we've done a relatively poor job of actually getting all of our people to you there in Trieste. But best wishes for the conference. But my job, a little bit different than it was going to be, had been there, would just be to provide a very brief introduction. And then, so as not to take up bandwidth and others, I'll sign off and hand back to John. But this session really is looking at issue of health infrastructure for quality care. So the question of infrastructure and sustainable change within a conceptual and aspirational goal of what's known as universal health coverage, and how that can be accomplished on the ground. And we have a few panelists who will be able to talk about the difficulties of realizing these lofty goals. I'll just frame it very quickly by saying most of you know that the Sustainable Development Goal era is upon us. These SDGs, as they're termed, are a new agenda for the development world to examine economic, social, and environmental dimensions of development, and they were adopted at the UN General Assembly at the Sustainable Development Summit this past September. It was at that summit where we talked about the role of primary care driving the health goals, and health is one of 17 goals that looks at trying to advance the SDGs. For us, we really see this as context in which goals in health infrastructure will be achieved, and And for WHO, the context recently of this past year has all been about the outbreak in West Africa of Ebola viral disease. And I suppose I suppose most of you were residing on planet Earth during the past 12 months, so I won't need to explain Ebola. But it was, suffice to say, a major crisis for our organization as well as other health organizations, looking at how an epidemic can really bring to its knees an entire society, and not just the health system. These countries, Sierra Leone, Guinea, and Liberia, as well as at some point Mali, at some point Nigeria, at some point Senegal, and at some point Guinea-Bissau, were affected by this. But it was not just that their health systems were weak, but also this brought to knees the entire economic system that the country maintained. And it's only now that they're recovering. We were involved quite heavily, our group, Nana included, who's there with you today, in the infection prevention side of this, and trying to ensure that patients were treated in the right way and that healthcare providers were kept from harm. But doing this in a context where over 50% of health facilities don't have access to clean water and other basic infrastructure that allows supply chains to function, not just for personal protective equipment. You saw the pictures of these people running around and moving around with these moon suits on, but also basic supplies such as antimalarials, so that when a patient comes through, you can't be sure if their fever is caused by Ebola or caused by malaria. So what do? Do you put them in the Ebola treatment area, or do you manage them in other ways? So there are all sorts of upstream issues, and for us, WHO, it's increasingly clear that this whole question of health security, which has become a very high-profile issue at the G7 level, is not simply a question of preparedness, of doing a better job of trying to get labs in place and track infectious diseases, but it's really an agenda about strengthening health systems and strengthening the underpinnings of those systems. So our panelists today will talk about some of that in terms of looking at the linkages between infrastructure and quality of care and universal coverage, as well as the links in Ebola countries, as well as some of these questions around water and sanitation and how those look at. And I think, although I'll leave it to John for really managing, I think for us, very interested in lessons from other disciplines as to how creating sustained improved performance in health systems, which involve a technical aspect, a technology aspect, as well as a people aspect. And in this case, it's not just sort of the people who are in the industry, i.e. Healthcare providers, but also the patients that they're serving. So it's even more complicated than many typical industries. But to then also get from some of you concepts about how this could be the lessons that WHO should broaden this out, and for some future work possibly together. So with those introductory comments, John, I'll hand it back to you for your stewardship of the rest of the session. And once again, thank you so much for allowing me to join and allowing our WHO to be part of this.
So thanks to Ed for that introduction. So as he mentioned, this is the first time that WHO has been involved in this series of meetings. And I think that for Robert and myself, the particular trigger for this was, of course, the Ebola outbreak. And I think that we would be very interested to learn, if there's anything that we can offer in terms of sure expertise or modus operandi, and I think that I'll now pass the word to Nana, who will tell us some of the key lessons on health infrastructure and quality of care from the early recovery experience in Ebola-affected countries.
Thank you, John. I actually have a short presentation, so we may have to switch from Skype to the presentation if it's okay. Bye. Thank you very much.
I'll sign off. Thank you very much. Over to you, Nan.
Hey, thanks, Ed.
Well, thanks for the introduction, John. And building on what Dr. Kelley has just said, I'm just going to shed light on what WHO has done on Ebola and health systems recovery in the 3 affected countries. And I should probably introduce myself. My name is Mensah, Abrampah, and I work as a technical officer in the Department of Service Delivery and Safety, focusing mainly on health systems recovery in the 3 affected countries. So before I start with the overall presentation, I just wanted to sort of give you an overview on the evolution of the 2014 Ebola outbreak in West Africa. The outbreak started in Guinea around March 2014 in a small village in the southwestern part of Guinea. Shortly after, it then spread to the capital of Conakry and neighboring countries such as Sierra Leone and Liberia. And then because we live in a globalized, interconnected world, the virus has since spread to 10 countries. And keeping this in mind, the World Health Organization declared it a public health emergency of international concern shortly during the latter part of 2014. Presently, the virus has affected around 28,000 people. This includes suspected, probable, and confirmed cases. Over 11,000 have died. And as we look into the epidemiology, we see that Liberia, 2 of the 3 countries have gotten to 0, and 1 is well on its way to getting to 0. So Liberia was declared Ebola-free around September 3rd, and Sierra Leone is looking to be declared Ebola-free tomorrow. Guinea is also well on its way to being declared, looking at the current epidemiological numbers. So what has been WHO's role in this whole outbreak/epidemic? WHO has played 4 main key roles, the first of which is the response phase. That is, how do you get to 0 and sustain a resilient 0? The second is research and development, that is looking at vaccines for the virus. And the third is on preparedness, which looks at how do you prepare the 14 or so priority countries, the majority of whom are bordering countries to the 3 countries, and the majority of whom are located in West Africa. And then the fourth area, which will be the majority of my presentation, is on recovery, i.e. how do you safely reactivate essential health services in the midst of an ongoing epidemiology, and also how do you tackle the root causes that contributed to the rampant spread of the outbreak. Before, I just wanted to quickly show this slide to give people a perception as to the different phases that is involved with this outbreak. So the first, from the start of the outbreak, which was March 2014, to December 2015 is what we call get into 0, that response phase, looking at community engagement, looking at safe burials, amongst others, looking at effective contact tracing. The second part, which is the early recovery phase, serves as the natural bridge between response and long-term health systems development. And this will be the majority of my presentation. And then the third and fourth phase is looking at long-term systems rebuilding. I mean, it's also important to highlight that before the outbreak, each of the 3 countries had made progress to improve the health outcomes of its people. However, the outbreak had a profound impact on the provision of essential health services. Arguably, the general consensus is that Ebola was due in large part due to weak health systems in the 3 affected countries. And I'll just give you a few statistics, the first of which in Liberia, we noticed that the epidemic contributed to significant declines in utilization of care, i.e. it contributed to about 61% decline in outpatient visits. When we look at Sierra Leone, we see that similar declines were also noted in first ANC, which is antenatal care visit, which was at 43%. In Guinea, we also noticed that the lack of confidence, the lack of community confidence in the health systems to deliver safe and quality health services led to about a 58% decline in primary medical consultations. In addition to that, the most vulnerable population of this outbreak is arguably health workers, who in a preliminary report developed by the World Health Organization noted that depending on where you are, you're between 7 to 32% more likely to be infected by the outbreak. So, it is important to highlight that WHO and partners have worked with each of the 3 countries to develop post-Ebola recovery plans. That is, how do you safely reactivate essential health services and build and tackle the root causes that led to the rampant spread of the outbreak. In working with the 3 countries, we've identified key technical areas that are pivotal in this to help the countries safely reactivate essential health services. The first of which is IPC, which is Infection Prevention and Control and Patient Safety. And this looks at a comprehensive approach, taking into account knowledge, processes, systems, competency development exercises, amongst others, which are necessary to avoid harm in health facilities. The second one, which we've heard about, is the linkages between water, sanitation, and hygiene, as well as even the energy sector, which proves to be highly critical when trying to provide safe and quality health services. The second area which we've been focusing on is on surveillance. And this aspect looks at how it looks at the subnational systems, looking at county, prefectures, districts, depending on whatever country you're in, and trying to integrate subnational systems with national systems. We also look at how we can strengthen health information systems within these countries that have the capacity to, 1, prevent, 2, rapidly detect, and then 3, effectively respond to any threat. The third, I should say, which is quite critical and we've alluded to, is the health workforce. That is, how do you create a fit-for-purpose health workforce that is important in the immediate phase of an outbreak or recovering from a shock, and how do you sustain that into long-term health systems development? This aspect of health workforce also looks at developing a new cadre of health workers to respond to the needs of the population. The fourth major area has looked at defining an essential package of services that responds to the priority needs of the population. As I alluded to earlier, there have been over 28,000 people infected, with only about 11,000 who have died. Hence, that leaves a significant number of survivors. So how do you design service delivery systems to integrate healthcare services for the survivors, as well as the priority diseases that are ongoing in these countries? Because before Ebola, majority of these countries in West Africa were still suffering from maternal and child health issues. They had malaria, they had cholera, they had other things as well. So the 6 areas that are outlined below highlights the underpinnings of how we have been working in early recovery at WHO. The first one is having a people-centered approach to services, i.e. designing services with people at the core. And what Ebola taught us was that community engagement and patient empowerment is so critical when you're trying to design service delivery mechanisms. And so how do you look at the interface between facilities, between communities, and then between patients, which is quite pivotal. The second one looks at partnerships, and by partnerships, what I mean is institutional health partnerships, and building on the legacy work of WHO's African Partnerships for Patient Safety program, which looks at not just North-South, but also South-South, and also within countries as well. And I think one of the important lessons here is the co-development as well as the bi-directional learning that takes place through partnerships. The third area of work is on information, communication, and technology, which I think can speak to majority of the audience here, is a lot of these systems in West Africa aren't operating at optimal capacity. How do we then build and then strengthen these systems in place to be able to deliver effective health services and aid in trying to detect the next potential outbreak or epidemic? The fourth area of work has looked at supply chain, that is timely and effective access to medicines, to gloves, to, as you all have seen on the TV, the white coat that is so synonymous with this outbreak. And then the fifth area has looked at health finance, and also within the context of universal health coverage, and also looking at how we can increase access to essential health services from some of these populations in these affected countries. And then the final area is knowledge harvesting, because in everything that you do, you need to somehow think about contributing to the global evidence base that can inform other countries who are going through a shock, or other countries that are recovering from an outbreak. So just in closing, I would just like to highlight that these key pillars have contributed significantly in addressing the early recovery phase in the 3 countries, and also have contributed to the safe reactivation of essential health services. They play quite a pivotal role in laying the foundation for these 3 countries to build back better, and also to sustain the momentum that we've gained as a result of Ebola. Thank you.
Okay, thank you very much. So perhaps if I may, just a couple of questions. So you mentioned this issue of dealing with survivors. So we've been hearing recently that there's a lot of adverse longer-term health effects for Ebola survivors. How much of a load is this?
Thanks for the question. And this is one area of work that WHO has been working quite closely with the 3 affected countries to be able to determine what sort of package that survivors need, because as you are well aware, once someone recovers from the virus, there are still some clinical issues that that person has to address, from eye problems such as glaucoma to joint issues, amongst other things. And I think this is where we as a global community can work to help these countries in trying to, one, define a package of services for the survivors, and then 2, trying to integrate these defined package of services for the survivors into routine health services, because not creating vertical programs will only put us back to square one. So I think these are some of the issues that as a global community we can help address, and looking at how do we, if there's technologies that can assist trying to identify, if a survivor needs to get to a healthcare facility, if there are technologies that can look at identifying, a health facility that within, preferably close proximity to them. I think these are some of the areas that can be critical in addressing some of these issues.
Yeah, I guess that's part of a larger issue about building resilient health systems. So do you have some sort of summary of what you consider to be essential for developing systems that can withstand such shocks in the future, keep functioning, and hopefully progress further towards universal healthcare despite these shocks?
Yeah, I think for a resilient health system, there's key dimensions of such a system. The first one I think of is having an integrated health information system that is able to detect, prevent, and respond efficiently to any sort of emergent threat that can come out. The second one is a system that is able to withstand shocks withstand shocks, as well as provide essential health services while concurrently responding to the outbreak. The second one is the third area is a system that places people at the core of its work, because health systems are made for people and engages communities effectively within the continuum of care and is able to learn from patient perspectives. And I think it's also very important to highlight within the context of the Sustainable Development Goals that health systems that are progressing towards universal health coverage, not just on the access part, but also universal health coverage with quality of care dimensions. Because as we like to say, what good is access if there is no quality or safety dimensions? So those are just the three core areas that come to mind.
Okay, thanks. So I think many of us associate Ebola with valiant health workers wandering around in moon suits, and you also mentioned the importance of WASH, right? And I think that brings us naturally to your presentation, Marcos, who is going to talk about WASH in Ethiopia. So I think we need to, you have a presentation. Iqbal, could you? So while they're just switching over, Nana, you mentioned ICT, possibly being an interesting interface with this community here. And you also mentioned knowledge harvesting. Is there a role here for analyzing data from mobile phones? Or is mobile phone, I mean, these are the sort of the mobile computers that almost everybody in that part of the world has. What sort of a role could they play in this?
I think as we like to call it in public health, mHealth, eHealth, mHealth being mobile health and eHealth being electronic health, plays quite a pivotal role in this outbreak. And from an infection prevention and control angle, what we've learned from this outbreak is, or what we've utilized is the mobile phones as an assessment tool, and designing some sort of assessment tool on mobile phones so that when healthcare workers or people from the subnational health systems go into these health facilities, they are assessed by a certain standard, because all these three countries have now developed standard norms on how to comply with infection prevention control standards. So once they go into these health facilities, and because mobile phones, as majority of you know, are quite, prominent in not just West African culture, but also the sub-Saharan African continent as a whole. If these health workers or data collectors go into these health facilities, they already have pre-developed data collection forms that they're able to fill, either on the mobile phone or if your battery's running low, they can also record it on paper. And then there is actually a database platform, which I am not an ICT person, but there is one that the name is not coming to me, but has been developed specifically for Ebola within the context of infection prevention and control, because that was one of the areas that was highlighted as being weak during this epidemic. And I think that's one of the areas that we can really think about, i.e. either building on that or strengthening that to make sure that these assessments that are collected are either transferred to the subnational system and then transferred to the national system and then made easily accessible to healthcare managers and district health teams for them to be able to use it for informed decision-making and also to improve the delivery of health services.
Okay, thanks. Okay, Marcos.
Okay, I'm Marcos Paulos from Ethiopia, Ministry of Health. I am working in the Medical Service Directorate as Assistant Director. Thanks you all for giving this chance. First of all, the WASH program concerned the National Hygiene and Sanitary Strategic Action Plan forms a key element of Ethiopian Universal Access Plan for Water and Sanitation, and highlight the important achievement of the GTP and the health sector program. The National WASH program has a multi-sectoral approach involving I think the 4 ministers, the water minister, the education minister, and the finance and economy minister with the health minister with collaboration. The develop the plug through the Memorandum of Understanding to support the integrated WASH program that address the need of the individuals and the community, school, and health facility, more holistic and reduce bureaucratic comprehension and services. I can tell my presentation is more about the clean and safe health facility. That's the CASH initiative in Ethiopia. This is, follows this one WASH program. I think there is a background of Ethiopia. All of you know, Ethiopia is the oldest independent and second most populous country in Africa, follows to Nigeria. There are 9 regional states and 2 city administrative cities and population greater than 9 million. This is census 2007. Over the last decade, Ethiopia has made great improvement in many health indicators. Many initiatives in the country improve the cleanness and safety in health care facilities. The most, the one is the One WASH program. After developing the strategies from 2030 up to 2020, this before 2 years, the SPA census figures 67% of all healthcare facilities have improved water sources, and 80% of the functional lighting is there. I can't say this high cash or the clean and safe health facilities. This is the advantage of clean health facility, or to increase the patient confidence and to give quality service. The major objective of this initiative is to make health facility clean, safe and comfortable to patient, visitors, and communities. Mostly the hospital cleanness is the important determinant of the quality of care and patient satisfaction. This is the most important issues. The initiative is launching last year by a higher governmental official. This is the Deputy Prime Minister, Mensah Mokonnin. The launch in November 2040 at national level. After follows the regional and hospital level in the presence of higher official investors and professional and other partner organizational participate this launching program. Follow this, nationally established the governance management structure for the clean, safe health facility initiative. The higher level, the executive committee lead, secondly the project team and the audit team, and the executive team, the Deputy Prime Minister and the Federal Ministry of Health, state ministers and other partner organizations, community representatives, and the regional health bureau heads are the executive committee. Also in the project committee, the partners, the MOH directors and technical experts and development partners are this team. The audit team is independent, university development partners and others are engaged here. The scope of this initiative is mainly all health, focus on the hospital, but all health facility with the is the scope. Mainly the hospital, and in the hospital, mainly the project is working on the clinics, the wards, and the utilities, the kitchen, laundries, the grounding, and some area is the main focusing area. As well as the partnership, the private sectors, professional association and celebrities are the and the development organization like UNICEF, WHO, USAID programs are partnered this program. About the principle of this initiative, mainly the cleanliness is about altitude, not structure. This is the slogan that we use. Also, the clean care is the safer care. Health facility should be the healing place. Also, the cleanness is everywhere responsibility. The cleanness is not the responsibility of cleaners, but also the responsibility of all the health facility staff, the senior management, and the board itself. This is some action points. The progress to update this initiative, the implementation of IPPS national minimum standards improved from 54 up to 75, renovation and building of utilities, toilets, kitchens, washing area, then the major number of hospitals that I think greater than 100 of new laundry machines are deployed. Also, the alternative water source and the water storage installed for 24/7 hours. Adoption of hospitals by private investors and political leaders are conducted. In this part, in the main city, Addis Ababa, there is the big university hospitals. The Abrampah hospital is adopted by Deputy Prime Minister Mensah Mokonnin. This is one example. The other is the known famous athlete Haile Gebrselassie. It is a long runner. He is adopted one of Yakati 12 hospital in the main city. This is the one example of the adoption of the known or famous people to lead the cleanliness. The hospital level sustainability cleaning is led by senior physicians, also the hospital leaders. This is the one of the important point. Also the experience sharing exchanges by the hospitals, visit between hospital to hospitals. Also the best practice sharing in this area. This is the clustering of hospital to best practice hospital to develop their own local best practice and exchange it through the IHAC program. That's the cluster of Ethiopian hospital cluster for quality. This is the one area. Also, zero tolerance for unclean service and physical environment. This is the most important slogan to know in the hospital areas. Okay, I can say this, the most challenges in this program is the instilling the culture of cleanliness, mostly in the hospital. This is the medical staffs not remove their some unnecessary disposal of the uncleaned materials and the use of the quality services and the posting and some unnecessary things in the hall and the other issues is there. Also the delaying of the redesigning and of the infrastructure of the some hospital is some issue. Also the shortage of financial and material resources is the challenge. The lesson learned in this clean and safe health facility initiative is the involvement of political leaders and the investors are the key. Also the ownership by healthcare managers, health workers and clients and the public of the initiative. Common understanding of the cash, also the wash activity in the healthcare facility by government decision makers and the development partners is the one area. Also the development of national plan with budget allocation with one wash and the cash project and development at the audit tool is the lesson learned, is the sum of lesson learned. Thank you. This is my presentation.
Okay, thank you very much. So I'm reminded that wash, or cash as you call it, also turned out to be very important in the British medical system, where it turned out that the sanitary conditions were rather inferior. So maybe we have something to learn from you. I just wanted to pick up on a couple of points. One of which you mentioned towards the end, you talked about auditing. And my question is, do you have any metrics that you developed to see what the health impact of this cash program is?
Okay, mostly the cash program is to improve the altitude of the health workers and the community on the cleanness issues and the quality services. This is the one area. Also the clean care is also the safer care, because the big issue is not the challenge of infrastructure in the health facilities. The most challenging thing is the altitude for patient safety.
Yeah, I guess this brings me to a second question which I have, which is how you ensure that the critical elements in CASH or WASH are sort of really integrated into the functioning of a resilient health system. How do you make sure that this impetus is maintained? And I could just imagine that the Deputy Prime Minister changes, a new Deputy Prime Minister comes in, and the new Deputy Prime Minister says, oh, well, that was that guy's program, I'm going to have a different program. Or, one celebrity becomes less famous, another celebrity comes up, gets people interested in a different topic. So how do you ensure that this thing is a long-term, stepwise improvement?
Okay, thank you. The first thing is the change in the altitude in the environment. That's mean the change in the community level, a change in the health workers level, and the senior management and the board level. And the inputs, additional inputs are there. Some the renovation, also the compounding, and additionally the source, the backup source for water, electricity, and IP supplies is the most crucial points. But for altitudinal change, the focus is given for the political leaders and the investors. This is the most important for the develop the ownership politically, and for the community levels. This is the engagement, also the one area. This is
okay. Well, thank you for that. Yeah, I see a question at the back. This isn't really the full question period, but please, go ahead.
Oh, okay.
No,
because
please.
I came late, so I didn't know.
Come on.
Okay. I just wanted to ask, my name is Zehra Sayers. I wanted to ask, is there any training program associated with this, or education program? Because if you are talking about the system being established and, in fact, being institutionalized, I think there is need for training at different levels, even starting from schools. This is probably not the job of the Ministry of Health, but on the other hand, training of the personnel in hospitals or various functions that are involved in this. Is there any training program that goes along with this?
Okay, thank you, Madam. But the training programs are now conducted for deployed health professionals and the health students in the hospital areas. But this initiative shall be incorporated to the hospital and health center reform guidelines. All effort will be exerted to design the hospital week every year. This is the one of the method to sustain this program. And additionally, I believe that the most important tool for sustainability would be improve the altitude of the hospital staff and the management through regular engagement and accountability mechanism. This is the... Okay.
So it had already been, originally it was foreseen that we would have another participant in the panel discussion from Morocco, who was going to talk in particular about health partnerships between hospitals in Morocco and Congo. So we've got about 10 minutes left for discussion. Perhaps I would just ask Nana and Marcos whether they have any thoughts about health partnerships in general, just briefly before we go to the general discussion.
Okay, thank you. I think with regards to partnerships, one of the area of work that WHO has actively engaged in is a program called the African Partnerships for Patient Safety. And this program looks at how you can partner institutions in the north, which is north meaning developed economies, and institutions in the south, meaning low to middle income economies, and partnering them to focus on improving quality of service delivery. The partnerships have formed between institutions, namely in the UK and the US, partnering with institutions in Anglophone Sub-Saharan Africa, as well as Francophone partnerships partnering the French with Anglophone health facilities within Francophone Africa. And one of the key lessons learned from this partnership approach is that one, a co-development approach ensures ownership. Without ownership, there is no sustainability. Right. And I also like to put it the reverse. Without sustainability, there is no ownership. And also one aspect of it is building frontline capacity in patient safety through competency-based training exercises, but coupling that with quality improvement initiatives, because training alone will not lead to sustainability. You need to embed quality improvement mechanisms such as supportive supervision, such as mentoring, such as training, but goes beyond training to ensure that sustainability. The second or the third key area is the joint problem solving that brings these institutions together. And through that, there is that bi-directional learning, because it's not just someone preaching to the crowd, but rather it's an interactive approach to problem solving, not just learning from those in the north, but there are so many innovations in the south that can be transferred to developed countries as well. And also looking at how leadership plays such a key role, because without strong, engaged leadership and governance structures, there is no sustainability, and I'm continuously trying to hone this sustainability issue. So I think partnerships, in a way, transcend national borders, because through partnerships, learning flows in all directions. It's not just, coming from an institution in the UK to an institution in Ghana, but also there's so much that, Ghana can offer institutions in the UK, as well as the institutions in other African countries, such as, my Ethiopian colleague here. And then it also creates this level of global solidarity, because there's an African proverb that says, one head alone cannot solve the problem, but rather when we come together and join forces, we're much more united and can adequately tackle the global issues at hand.
Okay, thank you for that. I particularly appreciate the African proverb. So, Marcos, do you have anything to add? Okay, fine. So now perhaps we all can open up the general discussion. I think it would be helpful if we could identify a few action points during the course of this discussion. Lionel, I think I saw your finger go up.
Bon, je vais poser ma question en français pour être sûr de ne rien oublier.
I would like to put this question in French so as to make sure not to forget any important point. Well, as for Ebola in Western Africa, and I know that something that interested me a lot, you did mention the risk assessment and what, in fact, is what are the health professionals to do? Because, for instance, that you ask them to, in fact, to be there, confronted with a disease that they do not even understand. And therefore, in training, risk assessment is of key importance and ought to be exposed as such. And I think that it would be important to speak about the lessons learned by these countries so that other countries in the region that, in fact, were not impacted by this disease, that they can improve their health systems and be in a better position to manage the disease in case there is an outbreak. Then this cash initiative, that seems very interesting. There are initiatives financed by the World Bank, and this is on the basis of the results so as to improve the quality of health services. And in other words, in fact, you evaluate this in a relevant matter, but also bearing in mind the quality of services provided. To do this in a collective manner. So what is of interest to me is, in fact, what can you say on this and whether there has been any question of this. I know that UNICEF was active in this, that there were also there was some work done in Belgium and so forth.
Talk to the Ebola-related questions.
Yeah, thank you very much for the question. And in terms of the lessons learned from the outbreak, I think I will hone in on a few issues that come first to mind. The first one is a health information system. Had there been had there been an effective integrated health information system at the subnational level, which is the first, and this is where primary care comes into play here. Had this been detected at the first point of service delivery, which is usually a primary healthcare system, and had it gone up the chains of the health information system, I strongly believe that this outbreak could have been avoided. And also we look at when this epidemic occurred, health workers did not know because it has very strong symptoms with malaria, which was what partly contributed to part of the delayed detection. So having trained health workers who are able to sort of figure when a situation is presented, their ability to triage, their ability to follow up, and also having lab systems in place to rapidly test for such, an infectious disease, all are such key critical dimensions of this outbreak. And then another area I would highlight is infection prevention control, which in the sub-Saharan Africa is quite limited in terms of, waste management, hand hygiene, safe surgery, amongst others. So really sort of rampant adherence to infection prevention and control in health, not just health facilities, because there's a community dimension, there's a school dimension, and then also looking at our national policies in place, and not just developing policies to address such issues, but also developing operational and implementation plans that effectively follow up on the strategic national policies that have been developed. And I'll note that all three countries have developed both post-Ebola strategic health recovery plans as well as operational plans on how they can tackle the gains lost due to the outbreak. And then, so those are just a few key things that I would highlight as lessons learned through this outbreak, with infection prevention and control and patient safety, as well as adequate wash infrastructure, which we've constantly heard from not just my colleague here, but also the previous session that we've had.
Right. Thank you. So, Marcos, do you have any comments in response to Leonel's second question, which was, I guess, basically about evaluation, in particular by patients?
Okay, thanks. In this initiative, there are 3 phases. The first phase is the preparation phase. Many things are in there. Also, the implementation phase. After that, the monitoring evaluation phase. In that phase, there are many issues integrated there. The first thing is the cleanness. Then follows the quality of all of the services. That service given to the clients, the national and the international standard basis, and the quality issues address follows. This is the first, the availability of water, electricity, the kitchen, the food service, the grounding. The most challenge, for many health facilities in the country. This is the most crucial areas.
Okay, thank you. I think, Robert, you had a question?
Well, I think it is common knowledge that many illnesses migrate from animals to humans. We know that. Now, to what extent is, for instance, Ebola the result of people? We heard this just before about food. And if people do not have enough meat, they can go and eat, bush meat. And do you believe this is a significant factor in something like Ebola and in future illnesses?
I think this is for you again, Nana.
I think in answering that question, one area I would highlight is what we call the One Health approach, because animal health, I mean, if you eat meat, it transcends quite closely. So how do we look at an integrated approach to one, not just health systems, but health security? And how do we also look at, from a One Health perspective, addressing some of these key critical health systems dimensions, such as having, an integrated lab system, and I constantly hone in on that because that is quite critical when trying to address such an outbreak, as well as also addressing the underpinnings of health systems, which feed very much into the other sectors, such as agriculture, which plays a critical, pivotal role, because without a strong, effective system that is integrated, not just with, health, but also with agriculture, looking at animal health, and also food safety, amongst others, can then also bleed into creating an enabling environment where all these different systems within the national level goes hand in hand in trying to tackle some of these issues of global concern.
Okay, thank you. I don't seem to see any other urgent questions, and we're out of time. So I'd just like to finish by complimenting WHO on the tremendous efforts that it made and it is making, in fact, all health workers, to deal with that terrible Ebola outbreak. And as you can see, there's many elements that come into combating such diseases, ranging from the ultra-sophisticated moon suits to washing one's hands regularly. And let's hope that the next time around, the world community will respond in a quicker and more effective way. As you said, if one had had the information at one's fingertips at the very first instance, then the whole shambolic mess could perhaps have been avoided. Thank you.